Good afternoon, everybody, and thank you so much for taking time out of what I know are very busy schedules to spend some time with us today to hear more about this complex legislation that is now in front of us. So just for a quick orientation, I've had a chance to participate on the advocacy committee for ASE for the last year or two, and it's just well-timed with the development of this legislation that is going to impact how we practice. Although I've had a chance to work and become familiar with this over the last year or so, I will share that I feel like many, we're still scratching the surface as the rules are literally being written as we go. So the purpose of what I want to do today is really just walk through the legislation and its background so that we leave after this hour or so with a better understanding of what's in front of us. I have no disclosures relevant to this discussion. For purposes of orientation for this talk over the next hour or so, there's really three areas that I want to focus on. First, why is it different this time? We've gone through so many other changes legislatively and so forth, but I think we would all confess by the buzz that's out there what is so different about MACRA. So I want to talk about that a little bit and about what's in front of us just in terms of from a 30,000-foot view in terms of healthcare. We'll then get into what I'll say are the nuts and bolts of the legislation. And then last, I would like to offer some very specific things that you and your teams can do to prepare for the environment that's ahead of us. So those will be the three areas. As Rana mentioned, please, if you have questions along the way, please send them in. If I can, I will answer them in real time, depending upon the answer to the question. Otherwise, we will take care of them at the end. For those questions that we can't get to on the call today, we will address them offline, and those will be posted on the website. So let's get into it. So part one, why it's different this time. What are the fiscal challenges that are really driving policy? I think if we're going to have any type of conversation about this, there's just a couple of, sort of level-setting things we need to do. So Medicare 101, you're all familiar with, the various terms, but I just want to make sure that everybody on the call has a clear understanding of the various components and parts of Medicare, which just celebrated its 50th anniversary last year. So there's Part A, which covers inpatient hospital services. You're admitted to the hospital with a problem. All the sort of hospital costs are included in the Part A spend. Then there's the Part B, and that includes physician services, both inpatient and outpatient, as well as all outpatient services. So this Part A, Part B duality is very important. Medicaid is a different program, as most know, that was created for coverage of the indigent, and then Medicare was expanded in the 70s and 80s to begin to include those, besides just the population 65 and older, those with Social Security disability and patients with end-stage renal. More recently in Medicare's evolution has been the development of Part C, which is Medicare Advantage, which are essentially, it's a Medicare HMO. This legislation does not affect these programs. And then I think we're all familiar with the Medicare Part D, which is the prescription drug program. So having a working knowledge of these components is important as we're moving forward in terms of legislation. The MACRA legislation that we're talking about and the associated physician evaluation programs apply exclusively to Part B, and that's physician or more broadly provider services. So just, again, for orientation, this is the scope, this is the landscape of what we're discussing. So here's the problem. This is a graphic from the Wall Street Journal. The figure that says 1970 is a snapshot of the age distribution of the population in 1970. And you can see the orange salmon band, which is the baby boomers. And you can see why we got the term baby boomer from the first place, just in terms of the population growth. And you can see from the line about two-thirds of the way up, the percentage of patients who were in their 60s and approaching Medicare. And I've put a couple circles there so you can see what things now look like some 46 years later. We can see that the number has increased dramatically in terms of the population above 65, but also what's critically important is look what's coming in terms of the size of the population who will be entering into the over 65 group in the coming years. This is not a blip. This is the new normal. The number that is quoted is 10 now, 11,000 people a day enter Medicare. So we've got huge fiscal challenges just in terms of the number of patients served. If we take a look at that in terms of the financing of this, and this is a graph from Kaiser Family Foundation, you can just see, looking back over time, what the total spend has been and what the relative percentage of federal outlays have been towards the Medicare program. But as we get into 2018, 2020, and beyond, you can see what's going to happen, and this is very predictable from an actuarial perspective from the graphic that I just showed you. So this is what's coming. This is no secret, and this has been known to policymakers for quite some time. If we take a look, and on all these slides, in very small print at the bottom are the actual websites, so offline with the PDF. If you're so interested, you can go to these sites and get these particular documents. But if in getting background information, and if you want to read some more, there are a couple of reports that come out each year about Medicare that are online. There's the MedPAC report, which gives us an update on the status of Medicare. There's also a trust fund report, which deals with the financing of Part A. And if you were to go into those documents, you would find something like this. So in this figure from MedPAC, this is from 2015, this looks at Medicare enrollment over time, which, as you saw from the previous curves, is going to go up. But what is also important is the curve on the right, which shows you how many beneficiaries we have relative to workers. So as we look over time, we see that at present we are, I think, approximately 3.1 workers supporting each beneficiary. And by the time we get out to 2030, that number drops down to 2. So we have more total number of beneficiaries who need to be served. We will have fewer workers in terms of payroll taxes and so forth who are supporting care. Looking in terms of actuarial projections, take them for what they are, but if you plug in what the Congressional Budget Office feels will be reasonable growth rates to expect over time, and you plug in what the math is in terms of Medicare, you can see that there's a certain amount of increase in spending that is just going to happen from an actuarial perspective just by the sheer numbers of people who will be receiving benefits. And as you look at that, and on top of that, put in the average increase in beneficiary spending that has happened over time, you see that the pace of spending for Medicare outgrows the pace by about 1.6, 1.7. So these are just the very important issues that are coming to light that are driving the policy decisions. And I think without working knowledge of these facts, the policy, any attempt for change is hard to reconcile against the status quo. Of all of these things, this is one particular graphic that I find very striking, and this is the trust fund that supports Medicare Part A. So in all of our paychecks each month, there's a portion that goes out to support Medicare, and that goes to the Medicare Trust Fund to support Part A, which is the hospital part of Medicare, as we discussed. This is from the 2015 trustees report, you can see that the trust fund goes belly up in 2030. Surprising there isn't more conversation about this with all that's going on politically. Probably not a whole lot of room for a debate around policy issues, but this is a math problem, and this is what we're faced with as we go forward. And again, just to orient you back to what the spending looks like as we're going forward if things are left unchecked. So, again, just some working knowledge. In 2016, the program, all said and done, is probably going to cost about $560 billion. You'll hear about different numbers, but then it's offset by payments and so forth, but about $560 billion. So just to give you a frame of reference, on $560 billion, if something saves you, if a program saves you $100 million, you're saving less than 0.02%, which I think telling in terms of just the overall size of the program. Presently comprises 14% of federal outlays and projected on current pace to be 27% of federal revenues in 2050, clearly unsustainable. We have now closer to 55 million on Medicare, and that number in a little bit more than a decade goes up to 82 million. So how do we handle this? What do we do? And this is this policy issue has been before us for some time. In addition, a lingering problem that existed from the outset of Medicare's creation was how to pay providers. There were felt to be enough checks and balances on the hospital side, but for physicians, and now we have many other providers in terms of nurse practitioners and others who are in this spend. We really did not have a great methodology for how to constrain spending. In the beginning, it was usual and allowable costs, and that led to escalation in costs and so forth. SGR was one of several methods. It was the last method we had before our present system, which really tied reimbursement to providers to overall growth in the economy. If the growth in provider spending was greater than the growth of GDP, mandated reductions in the fee schedule would happen. And so early in the program, back around 2000, this seemed like a good idea. The economy was humming. Physician fee schedules actually went up, but then in 2002, things began to reverse, and many on the phone will recall the annual issues with respect to, is Medicare going to cut us at the end of the year? And there were literally 17 acts of Congress to forestall any reduction in physician cuts in terms of reimbursement. So the SGR led to sort of a cliff each year that we were facing, and a great degree of efforts were put into place to repeal this, which ultimately landed into MACRA, which I'll get to in our next section in just a moment. But before we do, is we're looking through important legislation that has come along over the recent past. I want to take us back just for a moment to the Affordable Care Act, because we think about this with respect to the insurance issues and state mandates and so forth. We think about this legislation as a vehicle for improving access, which arguably it has been, and created a whole bunch of changes with respect to the insurance industry. But there's another important piece of information tied to this legislation, and that is it really set the stage for a lot of the quality programs that we're going to be talking about over the rest of this talk, in really shifting the discussion from the volume of services that have been provided. Remember, when Medicare started, usual and customary payment, it was assumed that things were appropriate and done well and done right and so forth, and it became an easy financial mechanism, just pay for what is coming forth, but really to shift to value. So how do you measure value, and what have been the initial attempts to do this? This slide may be a good takeaway slide for later time to reflect on, but if we really look at the Affordable Care Act, a whole host of programs were created out of this legislation, some of which affect providers, some of which affect hospitals, all of which affect patient care. So we know about the meaningful use requirements. We know about the development of accountable care organizations. We should be familiar with PQRS, the Physician Quality Reporting System. We'll talk a little bit more about that. And we'll talk about the Physician Value-Based Modifier. Those are the things that I've put in stars on this diagram. Additionally, those who have administrative responsibilities know about the hospital inpatient quality reporting programs and the readmission penalties and so forth. And these all have their DNA in the Affordable Care Act. If you're not aware of the impact of the previous slide on how things are happening today with respect to Medicare Part B payment, so if we're not talking about the hospital at all, we're not talking about readmission penalties on that side, if we're not talking about any of the hospital work, we're talking about the billing that providers put forth for their Part B services. As we add up the quality programs that have matured over the last several years, here's where we stand in 2016, 2017 with respect to the impact of quality. And we will spend the next part of the talk talking about how Medicare actually attempts to assay the quality of the services we provide. First, if physicians or physician organizations are not reporting to PQRS, there's a 2% loss in all Medicare revenue off the board. If we're not meeting requirements with respect to how we use the electronic medical record, the so-called meaningful use, there's another 3%. And as we get into the upper category, whether you're aware of it today or not, Medicare is keeping track of the perceived quality of the services that we provide and scoring those. And I'll take you through that scoring mechanism in later on talk. But all combined, you can see that of the services that are being provided today, 9% of all Medicare revenue. That's something that the general awareness of that simple fact throughout the provider community is not as pervasive as you think it might be. In fact, the general awareness of MACRA and the importance of MACRA within our provider community is not where it needs to be when we look at surveys from national organizations, part of the reason for our talk here today. So moving on, I hope I've laid the groundwork as to why change needs to happen if you're, from a societal view, a policymaker's view, an economist's view, what's really propelling change. So let's go through MACRA legislation and sort of how it works. So MACRA was the response to the SGR showdown that Congress and our representatives in our lobbying organizations would have every year about avoiding the cuts. And after many attempts at finding a resolution, it landed with the Medicare Access and Children's Health Insurance Program Reauthorization Act of 2015. So in that legislation, SGR was repealed for good. Those drops in physician fee schedule were repealed for good. With this, an increase of 5% in the fee schedule up to 2019 was put into place with a 5-year freeze. The reason I have the 0.5% in yellow is that's also contingent upon some other moving parts in the economy and some Medicare target spends. So, for example, last year, this did not happen. So there's an opportunity for a 0.5% increase in the fee schedule, but it's contingent upon some other moving parts with respect to Medicare. At 2019, things stop until 2025, which I'll get to talk. But the other elements of this legislation in terms of how payments will come forward are were intended to move the U.S. health system from one driven by volume alone, to one driven by quality and value. Now, a word here on what you see highlighted at the bottom, and I just want you to reflect on this, if you would, for a moment. If you think about the degree of polarization in political discourse today in the United States, what gets passed and what does not, take a look at these numbers as to how MACRA went through both the U.S. House, which is Republican, or was Republican at the time, the U.S. Senate, and then signed by a Democratic president. So when we're talking about this legislation, we need to keep in mind there is a mandate for this. There are no other counterbalancing proposals on the table. There's nothing else coming, nor is there a will for anything else to come. There will be modulation based on public comment, but these are the rules of the road, for the foreseeable next decade. So that's why our all becoming familiar with it and learning about this is absolutely critical. As we look at, again, going back to those reports that I showed you before from MedPAC and so forth, just, again, I think that this is sobering as well. There's still rumblings about Affordable Care Act being repealed or modified, what have you. It doesn't matter what side of the political fence you're on. If you just look at the actuarial aspects of things, we're going to see an increase in spending to 2030 no matter what. Real savings of any change really don't kick in until 2030. You can see what the actuarials project will happen with the combined impact of the Affordable Care Act with the MACRA legislation fully implemented versus where things look like without any kind of clinical change, with just sort of the routine changes that we've seen over time. Now, of course, there could be a third option that emerges from somewhere else that hasn't been proposed yet, but these are just what we're up against. So I think the likelihood of seeing repeal is very, very unlikely unless there is some other third strategy that is yet to be discussed in any meaningful way. So what's coming in 2019? Let's get into the mechanics with respect to the legislation and what this means. So it's just a glossary, some simple terms. MACRA, we've talked about it, it's the legislation. If you go to the CMS website, they're now referring all of the payment mechanisms within MACRA as the Quality Payment Program, QPP. And you'll see in the later slides, qpp.cms.gov. It's a new website that has just actually come online with the final MACRA rule, which came last week. And we'll walk you through a lot of the things I'm about to go through over the next 15 minutes or so. In this program, all providers are basically bifurcated to participate in one of two quality payment programs. There's what is called the Merit-Based Incentive Payment System, which we call MIPS, and then there are advanced alternative payment models. Okay. In this talk, we're not going to get into what we call AAPM. These are the accountable care organizations, and there are a variety of these. These are the shared savings programs, and there are different shared savings programs around episodes of care, around populations of care, around patients with similar conditions, and based upon how much risk one takes when entering those arrangements determines what type of track that type of program is defined as. The rules for these alternative, advanced alternative payment models continue to be evolving, but they tend to be delivering an expected outcome for an expected cost, and if you do better or able to deliver the cost at a lower rate, there's some savings to be shared. If your costs are more, then you're on the hook for those costs. For those who are involved in AAPMs, one of the incentives with respect to MACRA legislation is providing a 5% bonus for all routine Medicare Part B billings for the period of 2019 to 2024. 2026, when the Medicare fee schedule begins to take annual rises, this rise in the fee schedule will be 0.75%. So for those who are organized around the delivery of care in ACO or ACO-like models, for those organizations that are ready to take on risk, MACRA provides some incentive for people to move down that. If not, which is assumed to be roughly 90% of providers, then the default evaluation is the merit-based incentive program. But just for figures, around 600 to 650,000 providers will be assigned to the MIPS program. Generally speaking, your assignment to advanced alternative payment models or MIPS is really dictated behind the scenes by your billing, but obviously you have to have some type of formal ACO structure or shared savings program in place in order to participate in those programs. So let's spend some time going through the mechanics of MIPS, what it means and how it unfolds. So you saw the earlier slide where we talked about the physician value modifier, meaningful use, and PQRS. Those programs that have been in place for the last several years are all going away. They are now being recast or rebranded or reformulated into this MIPS program. The MIPS program has component parts that will look at physician quality. We'll walk through that in a few minutes. There will be a section in MIPS that will deal with the cost of care for various episodes. There will be a portion of MIPS which deals with our use of health information. And then there's a new category that's not reflected in the historical quality programs, which really gives credit for or benchmarks or monitors our participation in what are called clinical practice improvement activities. Things such as using registries, things as using checklists, and so forth. The performance period for this begins in 2017. I should put an asterisk next to that because I'll talk you through some of the options. As new options for reporting have been were announced in September informally, but are now part of the formal rule as it is coming out. So we'll walk through that. And then just another note for those of you on the call who participate in advanced alternative payment models, the ACO model that I touched on before. One of the benefits of participating in those models in which quality is baked into the incentive structure at the outset, there's no requirement or need for reporting in the MIPS system. So if we take a look at the domains within the merit-based incentive program, for 2017 there are only 3 domains. And this is new information. The final rule for MACRA was released online last week, all literally 2,390-some pages of it. It actually has not yet been formally published by the Federal Register. That will be in November. But the legislation is online and able to be downloaded for review. In 2017, although Medicare will be keeping track of physician costs, the score that is generated for any particular provider will not reflect that data. Be building what is called clinical performance score for every provider based upon how quality is measured, based upon this advancing care information, which is basically requirements around the electronic medical record, and then participation in improvement activities. And you can see the relative breakdown quality comprising 60% of the total score. In previous iterations, quality was 50%, and there was a 10% slice of the pie, if you will, for cost. That's probably what will happen in 2018, but we don't know that. So if we look at the various categories, and I'll walk you through sort of how these scores are projected to be calculated. Within the quality domain, one accrues points, and however many points you get results in a quality score. That quality score, 60%, will comprise 60% of the total overall score. In similar fashion, there are points to be gained with respect to advancing care information. There are points to be gained with respect to practice improvement activities, and each of these will comprise a score. At the end, there's a numerical score for providers, and based upon that performance is how penalties or bonuses will be assigned. So if we look at, go back here just for a moment. So if we look at one domain to start, let's look at the MIPS scoring with respect to quality. Similar to the PQRS system today that hopefully everyone on the call is participating in with respect to quality reporting, participants will have to report on 6 quality measures. Deep in the legislation are the details as to what percentage of your Medicare patients, I believe it's 50% in 2017, of Medicare-eligible patients do you need to report on for these quality measures, and also the methodologies as to how you report these measures. In many circumstances, these measures can be done through vendors, directly through your EMR, through third-party payers, even participation in certain clinical registries that serve as qualified data systems for reporting to Medicare. So there's not within the scope of this talk are the mechanics of how one actually reports these things, but there are 6 quality measures that need to be reported for the patient. Within this, the quality measures, one of which needs to be an outcome measure or a high priority measure. Depending upon the circumstance of the provider, there may not be 6 that are applicable to a population, in which case only the applicable measures need to be reported. For those on the call, presumably all in the cardiovascular field, there will be appropriate number of measures. Within the references later, I will take you to the pages within the legislation where you can actually get the measures, but just to give you an example of the high-risk measures for cardiovascular disease, and some of which would, touch on us with respect to our field, with respect to imaging, so appropriate use or non-use, if you will, of stress testing with respect to preoperative evaluation in low-risk settings, non-use of stress testing in patients post-PCI. There are other criteria in there with respect to blood pressure. Interesting, and there'll be some specifics with respect to the legislation on how we document receipt of specialist report, but those of us who are generating clinical information, how does that fall into our quality reporting? And then med reconciliation comes into play. It's just an example of some of the high-risk cardiovascular measures that are available for selecting. Now, because the final rule for Medicare has just come out, the tools on the website are a little bit limited. This is from the website prior to the final rule, just to walk through at the time how quality would be assessed and scored. And let me just take a moment for this, just to walk through this diagram. So in this hypothetical example, to the left, there are 6 measures. In addition, Medicare, from the claims data that go in, and I'll talk about that in just a moment, also has some other ways to assess quality or perceive quality from the administrative data. And you can see the number of cases that would be there for whatever particular measure. Based on the performance in that domain, there's a score that a physician or provider will receive. So in the first measure, that provider wasn't incredibly strong on a 10-point scale, got 4.1, whereas on the second measure, got 9.3 points. So this is all scored at the Medicare level. You can see at the bottom in the rectangle that in this particular example, out of 70 possible points, this provider scored 48.2. There are also some mechanisms for additional bonus points for some quality aspects that were outlined. And as I mentioned, as the final rule comes out, we would expect to see similar tools like this online to walk people through, how the numbers actually come out. So in this example, again, from before, Dr. Smith scored 48.2 points, got some extra bonus points, got 52.2 points out of a possible 70. So the quality score for this individual was 74.6. Now remember, that score is 60% of the total score. We would do the same exercise with respect to the other domains that we talked about in terms of the clinical practice improvement activities and as well as the advancing care information. So as we look at this, we just did the quality, aspect. Now there will be 80 to 90 points depending on group size, how many points you get. Again, we'll calculate the quality score, but as I mentioned, a similar exercise would go through with respect to the other domains. The new one is this clinical practice improvement activities. This is something that Medicare is using to try to strive our working together, our interconnectedness, our improving quality through this type of connection. So what are some of the examples of things that, would improve care and would count in this particular category? Examples as providers having same-day appointments for urgent needs and being able to demonstrate that. Using telehealth and group visits is one aspect of it. Another sort of high priority is the participation in the systemic anticoagulation program. And then one that I think is very important is the participation in qualified clinical data registries. And I think at a societal level, we'll be looking at this and what does that mean and what are the implications of it. I will tell you from my IAC days and in discussing with the leadership there with respect to accreditation that there's active work right now for the participation that hopefully most, if not all, on the call are engaged with in terms of accreditation with respect to echocardiography, that participation in those efforts will result in credits or points or what have you in the advancing clinic, the clinical practice improvement activities. That does not exist today. This is all new, but I just want to let those on the call know that this is a very active area and I think an opportunity for societies to pursue further action as legislation becomes better understood. So as we move forward, there's a clinical practice score that is generated for each provider, as I mentioned. Just to put a quick footnote in here, we'll come back to talk about this a little bit more because many of you might be saying, well, do we really need to do this? Is this something that has to be done? Is this something that evolves and so forth? And a lot of the conversation up until recently had been, January 1st, 2017, the clock starts, everybody's on the hook. CMS has softened that position. The way that it works right now for those elements that I was just talking about with respect to the scoring systems and so forth, there is certainly the option to report on a full year starting in January, so all patients from January 1st through the end of the year. There's an option for just doing it for 90 days, as long as those 90 days fall in a period between January 1st and October 2nd, in order to report. Even if you report one metric on one patient, that avoids a negative bonus in 2017. So this is really, CMS heard the feedback from the provider community that this is complex, we need more time, and they've really softened their position, but they are saying you have to do something. You've got to participate at some level. But they've set the bar very, very low for participation just to avoid having to pay a penalty. But for those who have just not done anything in this domain and are not going to participate and so forth, there will be a 4% reduction in all Medicare fees in 2019. Again, just as I mentioned, we're not talking about advanced APMs, but there's the 5% bonus if you're in the APM program. So how it works is like this. In 2017, you take care of patients the way you've been taking care of patients. I'll give you some recommendations in terms of how we think about that in the next part of the talk. But care is delivered. The reporting is done, whether it's for the whole year, as I mentioned, or whether it's for partial year. In 2018, these data are all collected and benchmarked and so forth, so that scoring is able to be determined. How did you do relative to your peers with respect to these scores? A penalty or reward is assessed that goes into place for all of the billings with respect to 2019. Then the same thing happens again in 2018, all the data that comes in and so on and so forth. So every year there will be, beginning in 2019, there will be a penalty that is based upon the performance of either the group or the individual from 2 years prior. So if we take a look at this with respect to how this all maps out, there will be a threshold score. So all the reporting goes in, all the points are calculated, and it becomes just sort of a statistical discussion. How did one do relative to one's peers with respect to these complex measures? Within this domain, if your performance is better than your peers, you will receive a bonus, and that bonus varies. I'll take you through that in the next slide. Each year, that bonus potential goes up, and equally, for performance below the mean, the penalty phase increases. There are also some accelerators with respect to bonus, which I'll go through here on this next slide. So if you look at this graphically, in 2019, if you don't report anything at all, your Medicare payment will be cut, Part B, by 4%. If you report something, you will avoid the penalty. But as we get into 2020, this is where the penalties really come into play with respect to your performance relative to peers, equally your benefit relative to your peers. This is a zero-sum game, essentially, that those who are below the mean will be funding those above the mean. If there are more below the mean, the 5% actually can go up even higher than that, just depending upon particular performance. And then as we look at exceptional performers, those who are better, those that are in really the top quartile, there's some additional funding that has been provided. So there is really opportunity if you really are well organized in terms of your care delivery and structures. There's really some opportunity here with respect to this particular system. As well, equally as mentioned, that there's risk. So if we put this all together in what the MACRA payment summary looks like, this slide will be updated with new web tools with the release of the final rule. You can see that there's been the opportunity for an increase in the fee schedule of 0.5% up through 2019, again, contingent upon other elements in the economy. Then things go into hold, and then starting 2026 on, if you're in an advanced APM, you get a 0.75 boost in all your payments each year. If you're in fee-for-service, as most people are today, the increase, it will be 0.25%, so there's less opportunity there. You can see from those who continue to participate in MIPS, the upside-downside risk that gets to 9% by 2022 and goes outward. The alternative APMs have a 5% bonus, I think, as an accelerator to get people moving into those types of programs, but that 5% bonus goes away after 2024. So, what do we do? How do we prepare for this complexity? What are some of the things you can take away today to begin to focus on this new payment system? And also, how does this impact those of us on the call who are deeply intertwined in echocardiographic services and imaging delivery? So let's just back up for a quick moment. Okay. how does Medicare know, as a provider, how does Medicare even know who you are? There's really three things that you need to know. If you're billing Medicare under Part B, you have a national provider number. You are in some type of collective organization that has a tax ID number. That's how Medicare, begins to assign how a performance is done by groups of individuals. And then within that group, there's a taxonomy. And this is something that becomes very important when we look at costs. So, behind the scenes, if you're a cardiologist, for example, and you joined a healthcare system, somebody in the billing office assigned you to be a cardiologist. Now, if you're an electrophysiologist, of course you're still a cardiologist, but an electrophysiologist offers a different array of services, has a different cost structure than a different expected cost structure. If the classification isn't right, it sets everything wrong with respect to all of the scoring that follows in terms of how Medicare essentially knows who you are. So this is very important housekeeping, homework to take away back to make sure that within your organization those things are well understood. How does Medicare know how you practice? Well, good, bad, or indifferent, Medicare generates what's called the Quality and Resource Use Report, the QRUR report. And this is generated by tax ID number. So all of the people in your group that you were assigned to when you joined your healthcare organization, or if you're in a private group, all those folks together are looked at collectively by tax ID number. This is the way Medicare processes claims data, registry data, electronic health record data, and so forth. When Medicare is looking at costs of episodes, they do this based upon physicians' how they're organized with respect to tax ID numbers. So attribution of costs is attributed to tax ID numbers. In addition, based upon claims data, the number of codes and the severity of codes that have been submitted, that is how Medicare makes determinations about how sick a patient is, and that becomes very important with respect to value-based cost assessment. So there's two issues here that I think you really need to, take away. Number one, how reliable are your coding systems where you are to really capturing all the important diagnoses that your patients have with respect to comorbidities? In many systems, it's not very refined, and if you're taking care of sick patients, the cardiac patient who also has peripheral vascular disease, who also has stage 3 kidney disease, who also has COPD, if those last three diagnoses aren't on the claims data, Medicare has no way to know how sick that patient actually is in terms of risk, and your subsequent care is not looked at through that particular lens. The other aspect has to do with the TIN, or the tax ID number. Tax ID numbers were really created to just be vehicles for billing, transactional relationships between providers and Medicare for moving funds for care. They weren't really built to be tools to assess clinical quality. So, for example, my group joined our healthcare organization over 10 years ago, and when we did, we were assigned to a large group within the group from a tax ID number. It has nothing to do with our operations, how we do go about our day-to-day work. It's purely a billing function behind the scenes. However, Medicare evaluates our performance based upon our tax ID number, which is all of the groups. So you can see how the specific work that we do as cardiologists within our healthcare system may be lost in the broad space of the tax ID number. This is something that you need to understand and begin to take back to your organizations to look at how you are actually organized within your organization in terms of your care delivery. Because ultimately, costs are going to come down to being assigned relative to episodes of care. So an episode of care, as Medicare would define it, would be something that is initiated by a trigger event. Patient comes in with an acute myocardial infarction, you can see in the one triangle. Then for a period of time, looking backwards, looking forwards, all the costs of care that are relevant to coronary cardiovascular disease and so forth become associated with that episode. A couple days before, can be 30 days after, 60 days, 90, depending upon the particular episode. things that are unrelated to the episode. You know, if the patient on day 45 fell down and broke his or her arm, those costs would not be part of the episode. But anything else, the echocardiogram on day 1 or the follow-up visit on day 4 or whatever you have would be included in the episode window. And those would be assigned to the specific tax item. This goes on today. When Medicare today calculates your physician value-based modifier, which I'll show you an example of in just a minute, from the QRUR reports, all this data from claims data that are going on behind the scenes that most of us as providers are unaware of are being tallied into various quality measures in terms of episodes, for cost, for performance in terms of outcome, and the costs that are associated with that. The QRUR reports come out, these reports came out in October by tax ID number. I'll show you how you can get access to these if you're unfamiliar with them. This is just an example. In this front page of a quality, a QRUR report, in the sort of bluish arrow, you can see that this person was fairly average with respect to how quality was assessed. They did a little bit better with respect to how costs were assessed, and when you plot that in the scatter plot, you can see that this particular person was a little bit better, as you can see, a little bit north on the cost axis, but basically on the line with respect to quality. So this would be somebody who would not get a bonus, would not get a penalty. This is under the existing system today on, what could be your quality and resource utilization report. Clearly, you would like to be more in that northeast quadrant of high quality, low cost, and you don't want to be in the low quality, high cost area. So this is information that you can get today that tells you how your group, as presently defined, is performing in this complex world of claims-based data and reported data and so forth. So what do you need to do as we're winding down here and having some time for some questions? So number one, make sure your taxonomies are correct. If within your tax ID number you have electrophysiologists who are labeled as general cardiologists, you're going to have a problem. If you've got interventional cardiologists who are labeled as general cardiologists, you're going to have a problem because those cardiologists are expected to have more costs. And if they're benchmarked against general cardiology, you're going to look as if you're more expensive than others. The QRUR data are absolutely critical. And this is organized by tax ID number. Also, there's a separate report that just came out called the Supplemental QRUR report that is not used for calculations, but actually gives you case-level data that tells you about specific patients and how you took care of them for specific episodes. I'll go through that in just a moment. But then the last thing that is absolutely critical is you have to look at how coding and documentation is done at your organization in terms of the relative severity of illness of your patients. Because if you're undercoding in the sense that you're not getting credit for how sick your patients are with respect to comorbidities, Medicare thinks you're taking care of a healthier cohort and risk suggests appropriate. So as we're running out of time, these last couple of slides here just are basically some resources you can go to online that tells you how to get a QRUR report and other types of things. So as we look at it here, what can you learn from this? From your supplemental QRUR report, you can tell of all your patients with heart failure, you can look at resource use, and you can look at it by provider. So if you've got care provided by hospitalists, do they order more echoes or fewer echoes than your patients who are cared for by cardiologists? What are the outcomes of those patients? How many echoes do you routinely get for an episode of care for myocardial infarction? You can get these data from the supplemental QRUR report. And then also indexing severity. How sick are your patients relative to your peers? There's a question that has come up, where do we get the quality measures? Here's where they are. And online today, I've got the reference with respect to the actual pages on there with 2207, but the official publication comes out on November 4th, but you can get this online today. The late-breaking news, again, I mentioned before about how you have the option just to report for one metric to avoid a penalty. A greater amount of time for 90 days will get you some opportunity for bonus, and the whole year will get you the full bonus. Regardless, the way it works is that you report all of your performance data in the first quarter of 2018. So you take care of all your patients in 2017, and then in January, and I believe it's by February 28th, you report all your data, say, here's how we did last year, whether that's for one patient with one metric, whether that's for 90 days on your population, or whether that's for your whole year. So what's the takeaway here? We have to be really looking at the variance in the care that we provide. I mentioned the example about echoes in heart failure or echoes in myocardial infarction and so forth, and I think if most of us do some reflection on how much variance we have, it's because we don't, most institutions don't have care pathways, don't have a standard way of taking care of these types of things. So we really have to begin the conversation about how do we take care of common conditions in common ways, and what resources do we use and when, because it all will add up, and we'll be able to, uncover differences through these types of methodologies. And, in closing, remember, what we receive back is virtual. At a stroke of a pen, things can be cut by 5%, 10%, and whatnot, yet our costs are real. We have salaries and capital and people who depend on us, so our costs we're writing each month, and the revenue is vulnerable. So we have to make sure that these are matching. This is the website where this talk will be and other resources for you. I know we went pretty quickly in this hour. I'm going to go through a couple of questions here as we're moving forward. I hope this was helpful as a point of entry. It's a lot to absorb, but as I mentioned, the time that you spend learning about this will be, I think, time well served in terms of your organization. So, taking on a couple of questions very quickly, to clarify right now, this is just for Medicare. Yes, this is Medicare's program. However, the private market tends to follow Medicare, and as we're moving towards a value-based system, standardization of metrics, and so forth, this will be shaping the private insurance market as well, and we think that this will be coming very quickly, as it has seemed to follow. There's a question, will advanced APM providers be free of MIPS reporting? Yes, if they qualify. There's a whole different complex conversation about AAPMs. There's certain revenue thresholds that need to be achieved, and if those revenue thresholds are not achieved, then the provider defaults back to MIPS. So that's a more complex topic that I can't really go give sufficient detail here on the call today. But something that, for those of you in APMs, need to be very, very familiar with. Who scores the quality? Again, the quality is assessed by the reporting that we send in, and it's aggregated by CMS. Is the quality scored by individual doctor or group practice? The answer is yes. It can be either one. You can report at the TIN level, at the group level. You can report at the individual level. You can't do some at the individual level and some at the TIN level. It's as written right now, and unless there's something buried in the 2,400 pages of language, that's how it is. It's one or the other. Certain things will be done in the background by TIN level in terms of cost, but it's something that's selected up front and is designated usually by the 30th of June in terms of how you're going to report. In terms of, so the question came up with how are we going to actually measure the AUC with respect to performance data. So the language hasn't been fully clarified in the final bill in terms of how the AUC will be reported. This is going to be an area, and we'll report back to that on the website because I think this is going to generate a tremendous amount of interest, as this is a high priority metric. So we will make certain that we've got follow-up language on that. Also, how many patients do we need to report on and so forth. So I think that for the ECHO community, that's going to be an important aspect. Someone had asked where the quality measures could be found, and I mentioned that, within the talk. And then how are they going to have all of these options set up for the first of the year? Apparently, Medicare is ready for this. I think the challenge at the tax ID number level really comes down to who's in your group and how will your group look its best. So as I mentioned, I'm in a tax ID number comprising 976 providers, from primary care to other subspecialties and so forth. So we actually spend a fair amount of time looking at our group level performance and where we excel. One of the advantages of all of these programs, whether it's PQRS that is sunsetting or whether it's this one, is you get to pick what you want to report on. You get to tilt the scales your way, but it requires an investment inside your program. As we are winding down, there's a question here. So many times we're repeating echocardiograms from other facilities that have done a poor job. If our repeat echo is done within 6 months, we are penalized because we did a second exam. This gets back to the issue with respect to quality and quality reporting, because care episodes are going to be attributed back to providers, and the more tests that are done, obviously the higher the cost. The attribution language as to who owns the visit or who owns the care, again, is an hour talk, if you will. But to keep it simple, for an inpatient admission, all the costs that are associated with that goes to anybody who provides 30% of the E&M charges during that episode. So patients admitted with heart failure, any physician who's providing at least 30% of the E&M visits will be tagged with the cost from a cost perspective. For a procedural episode, it will be the provider who did the procedure. So if somebody comes in with an acute myocardial infarction and gets a stent, that invasive cardiologist owns the visit and then owns for the period thereafter. So this is why, at group level reporting, groups are going to have to look at their performance in places that are organized with referral-based clinics where it's their own group, but in a different site. Obviously, having one set of standards with respect to imaging becomes critically important. I think the takeaway message from all of this is that for those of us who are, in the echo field and we have been pushing for quality for so long, I think this is going to create a new day for this, because the value of the study that you're performing, and not just the volume, but the value, the timeliness, the completeness, the accuracy, and so forth, is going to take on whole new measures with respect to how we take care of patients. The reliance on that data, because based on what that information shows, will dictate what we do thereafter. So I think that, as we move forward, I've scratched the surface on this, hopefully a bit for everybody. This isn't a one and done. It's an area that will continue to evolve. We'll have more updates from the advocacy group and from the advocacy page moving forward. We will address other questions that came online. Afterwards, we've got the link that's up for you as well. And again, I want to thank everybody for your time and attention today. I know this is not the most glorious topic to have to review, but it's one that we all need to be familiar with. And I thank everybody for your kind attention today. Thank you very much.